Good afternoon, everyone. Today, we'll delve into a critical aspect of managing congestive heart failure, or CHF, the often complex and sometimes problematic interaction between two cornerstone therapies, beta blockers and pacemakers. Living with CHF is a delicate balance, and while both these treatments are vital, their combined effect can lead to unexpected challenges for our patients. Our goal today is to understand this dynamic interplay and explore strategies to optimize patient care and outcomes. In CHF, beta blockers are foundational, helping to block the harmful effects of stress hormones on the heart. Pacemakers, on the other hand, are implanted to prevent the heart rate from dropping too low, often enabling us to safely introduce or escalate beta blocker therapy. The challenge arises when the beta blocker effectively slows the heart's natural rhythm, prompting the pacemaker to take over more frequently. This constant override can disrupt the heart's natural physiology, leading to frustrating symptoms like persistent fatigue, poor sleep, and even a worsening of cardiac function. Let's visualize this as a tug-of-war. The beta blocker is actively pulling to slow the heart rate, a key mechanism for its long-term benefits in CHF. Simultaneously, the pacemaker is set to maintain a minimum heart rate, acting as a safety net. When the beta blocker suppresses the intrinsic rhythm, the pacemaker effectively wins the tug-of-war, taking over the heart's pacing. This can mean the patient doesn't fully achieve the desired heart rate reduction from the beta blocker, yet they may still experience its potential side effects, with the pacemaker constantly overriding the heart's natural rhythm. This constant override by the pacemaker, driven by the beta blocker's suppressive effect, can be profoundly unsettling for the body, often perceived as unnatural and inefficient. Patients frequently report increased fatigue, feeling perpetually run down, because the heart's mechanical and electrical activity might not be optimally synchronized under frequent artificial pacing compared to a more natural rhythm. Sleep is also often disrupted, leading to insomnia or non-restorative sleep. Furthermore, even with a maintained heart rate, overall cardiac output and oxygen delivery might be suboptimal, contributing to shortness of breath or lightheadedness with activity. This interaction isn't just about uncomfortable symptoms, it can trap patients in a detrimental cycle that worsens their CHF. The debilitating side effects often prevent patients from tolerating the optimal, guideline-recommended doses of beta blockers, thus compromising the medication's disease-modifying potential. Severe fatigue leads to deconditioning, further exacerbating heart failure symptoms. Chronic insomnia can trigger stress responses, counteracting the beneficial effects of beta blockers. And critically, a reduced quality of life due to these symptoms can severely hinder adherence to the complex CHF management plan, undermining overall treatment success. It's crucial to understand that these non-cardiac symptoms of fatigue and insomnia are not benign. They have significant implications for the long-term health and survival of CHF patients. The inability to tolerate optimal beta blocker doses means patients may not receive the full neurohormonal blockade necessary to slow disease progression. Chronic sleep deprivation and persistent fatigue are linked to increased inflammation and sympathetic nervous system activation, raising the risk of adverse cardiovascular events. A decline in functional status from fatigue is a known predictor of poorer outcomes. And, perhaps most concerning, these unresolved symptoms can lead to poorer adherence and are independently associated with increased hospitalizations and higher mortality in heart failure populations. Successfully navigating this tug-of-war demands a highly nuanced and personalized approach. It's not about simple fixes but requires intricate assessment and a multifaceted strategy. The decision to adjust pacemaker settings, particularly the lower rate limit, is a specialized maneuver best undertaken by a cardiologist or electrophysiologist. Our strategies will encompass careful pacemaker programming, thoughtful beta blocker management, and increasingly, the consideration of advanced pacing techniques. Before making any adjustments, a thorough assessment is paramount. First, we must confirm that the patient's symptoms are indeed due to profound bradycardia from the beta blocker and not other common causes like anemia, deconditioning, depression, or sleep apnea. Next, a detailed interrogation of the pacemaker is essential. This includes reviewing the percentage of ventricular pacing. High percentages are a red flag for pacing-induced desynchrony. We also need to understand intrinsic heart rate trends and ensure proper device function by checking lead impedances and thresholds. The rationale for cautiously increasing the pacemaker's lower rate limit, or LRL, is to provide a safety net, ensuring the heart rate doesn't drop to dangerously low, symptom-inducing levels. This, in turn, creates a window of opportunity to slowly and incrementally increase the vital beta blocker dose to a therapeutically effective level, which might otherwise be impossible. This directly improves symptomatic tolerance. If an LRL increase is necessary, it's done in small increments, and patients are continuously monitored for their symptomatic response, vital signs, and importantly, the pacing burden. This is a crucial slide. Prioritizing pacemaker optimization features is paramount. Modern pacemakers are equipped with algorithms, such as Medtronic's MVP or Abbott's Rhythm IQ, designed to minimize unnecessary right ventricular pacing. They constantly monitor for intrinsic conduction and only pace when truly needed, promoting a more physiological rhythm. The problem arises if the LRL is increased without activating or optimizing these MVP features. The pacemaker will then pace the ventricle nearly 100% of the time, leading to ventricular desynchrony, paradoxically worsening heart failure symptoms, reducing cardiac output, and contributing to pacing-induced cardiomyopathy, thereby causing more fatigue and insomnia. Additionally, fine-tuning the AV delay ensures optimal ventricular filling and contraction, especially when pacing becomes more frequent. The ultimate goal of these adjustments is not simply to pace the heart faster, but to enable the patient to tolerate and achieve the optimal beta blocker dose. Beta blocker titration must be done with extreme caution. The dose is increased slowly, and if symptoms recur or the pacing burden becomes excessively high, the dose might need to be stabilized or even reduced. It's a continuous, patient-specific balance between achieving the life-saving benefits of beta blockade and minimizing pacing-related side effects. The choice of beta blocker can also play a role, with some being better tolerated in certain individuals. When beta blocker tolerance remains an ongoing issue, clinicians should actively consider other guideline-directed medical therapies that offer neurohormonal blockade or other benefits with less impact on heart rate. ARNIs, like Entresto, primarily affect blood pressure and fluid balance with a generally neutral effect on heart rate. SGLT2 inhibitors, such as dapagliflozin or empagliflozin, have emerged as foundational CHF therapies with no significant heart rate impact, making them excellent choices in this scenario. In some severe cases of bradycardia that preclude crucial beta blocker uptitration, a pacemaker might even be proactively implanted specifically to enable optimal beta blocker dosing, thereby improving long-term outcomes. Patient education and empowerment are non-negotiable. Patients must be educated on the importance of promptly reporting any new or worsening symptoms like fatigue, dizziness, or sleep disturbances to their cardiologist. It's crucial to emphasize that beta blockers are vital for long-term CHF management, and patients should never discontinue or alter their medication dose without direct consultation with their healthcare team, even if experiencing side effects. Finally, encourage lifestyle adjustments, including good sleep hygiene practices and regular, physician-advised light exercise, to help manage fatigue. While conventional right ventricular, RV, pacing, especially at the apex, can lead to ventricular desynchrony and worsen heart failure over time, newer physiological pacing modalities offer exciting potential. These approaches aim to activate the ventricles more naturally. One such technique is his bundle pacing. This involves placing the lead directly into or adjacent to the his bundle, allowing the electrical impulse to travel down the heart's natural conduction system. This preserves ventricular synchrony, can narrow a wide QRS duration, and has been shown to improve hemodynamics in CHF. While technically more challenging, it offers significant benefits. Another promising physiological pacing modality is left bundle branch area pacing, or LBBAP. Here, the lead is implanted into the interventricular septum to capture the left bundle branch, promoting a rapid and synchronous activation of the left ventricle. LBAP offers a high success rate and stable pacing thresholds. It's particularly effective in correcting left bundle branch block and is emerging as a strong alternative to conventional cardiac resynchronization therapy. Like his bundle pacing, it avoids the deleterious effects of chronic RV apical pacing. These modalities are particularly considered for patients with a high anticipated ventricular pacing burden, those with pre-existing heart failure, or candidates for CRT. It's vital to reiterate the potential problems if these strategies are not implemented properly or if optimization fails. A high percentage of ventricular pacing without optimization can induce or worsen ventricular dyssynchrony, leading to increased fatigue, shortness of breath, and exercise intolerance. Long-term, high-burden right ventricular apical pacing can even cause pacing-induced cardiomyopathy. More frequent pacing also means faster battery depletion. Critically, a constantly paced, non-physiological rhythm can still contribute to chronic fatigue and sleep disturbances, defeating the purpose of symptom alleviation and ultimately compromising long-term longevity by preventing optimal beta-blocker dosing. In conclusion, the intricate interplay between beta-blockers and pacemakers in CHF patients truly presents a unique tug-of-war that demands a highly nuanced and personalized approach. The seemingly non-cardiac symptoms of fatigue and insomnia are far from benign. They significantly diminish quality of life, hinder adherence to vital therapies, and ultimately accelerate heart failure progression, impacting long-term survival. Effective management goes beyond simply maintaining a heart rate or blood pressure. It requires diligent diagnostic assessment, meticulous pacemaker reprogramming utilizing optimization features like MVP and AV delay adjustment, and careful beta-blocker titration to achieve the maximum tolerated, guideline-recommended dose. Crucially, clinicians must also consider newer physiological pacing modalities like his bundle pacing and left bundle branch area pacing to deliver more natural ventricular activation. By prioritizing this holistic, patient-centered care, integrating both established and cutting-edge device therapies with optimized medical management, we can proactively alleviate debilitating symptoms, improve functional capacity, and truly enhance the overall prognosis and quality of life for individuals living with CHF.